Hiya. Can you all see my screen? Can you just type in the chat box if you can see my screen? And also if you can hear me as well, please. Cool. All right. My name's Kev Tang. I'm one of the radiology trainees in South Yorkshire. I've also got with me Dimitri, who's sat to the right of me. Do you want to put your head in? He'll be giving the second half of this, but when we ran through this yesterday, he had some technical issues yesterday, so he's just come over, so we'll just do it both from my computer. So this is part of the F1 survival series. So this session is going to be in two halves. So the first half is going to be an overview of the radiology service, and then we'll go into different modalities, why you do each one, and then we'll talk about vetting, which I think is what is probably most of your concern. It certainly was my concern when I was in F1. And we'll talk about how you can discuss effectively over the phone and how to not be essentially scared of talking to radiology on the phone. Because I think it's a big fear of F1s, but it doesn't need to be. And then in the second half, Dimitri will go through an approach to on-call chest x-rays, and then there'll be loads and loads and loads of cases. So your participation would be really helpful. It's all a sort of a safe learning environment. So we're going to go through each chest x-ray one by one, and then we'll talk about why it's this, why it's not other things. So hopefully when you see it in real life, you'll feel a lot more prepared and a lot more confident at 2 a.m. with a desaturating patient. So as a result, this talk is probably going to be quite long overall. It'll probably go till 9 p.m. or so. But hopefully you're expecting that from the information when you signed up anyway. So yeah, let's start. So the outline for this one, we'll go through who's in the radiology department and what consists of the radiology department. And then we'll talk about the basics of each scan modality, the pros and cons, and when each one might be appropriate. And then after that, we'll talk about requesting scans, vetting, and then we'll go through some case-based discussions as well. So there's loads of people in the radiology department. There's radiology registrars, radiology consultant, there's reporting radiographers, and then there's radiographers for each individual modality, so CT, MR, ultrasound, X-ray, as well as the nursing staff. There are clinical imaging assistants, which are essentially clinical support workers, but they help with the sort of the positioning of the patients and stuff. And then there are of course, the admin staff as well. One of the big roles, as we all know, is vetting and reporting scans, and we'll go into that in the second half of the talk. We also do lots of dynamic imaging, so this is where you use time as a variable as well. So using ultrasound, it's important you can see what things are doing in real time, as well as in fluoroscopy too. We do lots of image-guided procedures. A lot more than I was aware of when I started F1. So these would be like drains, biopsies, placing lines, placing catheters, and this is where a lot of interventional radiology comes in. There's a big role for radiologists to take part in the MDT, and this is actually probably not something that we're aware of that much as an F1, F2, because they kind of take place behind closed doors, involving quite senior members of various specialties. But it's a big role that radiologists play in terms of being able to provide image interpretation and discussing with other members of the MDT and how to manage the patient best. And then the member of the team that you guys will be interacting with most of all is the duty radiologist. So this is the person holding the bleep for the radiology service and is usually the first point of contact for pretty much most of your queries. So we'll go through the types of scans. So we'll start with X-rays. So the most common indications are probably these four. So looking for fracture lines, looking at the chest to see if there's any cardiac or respiratory pathology. There's lots of X-rays of sort of peripheral limbs to look for bony pathologies. And then one that you guys might have a bit of a role in, depending on sort of trust to trust, is deciding whether or not lines are placed correctly. So this will typically be NG tubes. And because of this, Dimitri's going to go into a few cases with different lines and different NGs and whether or not they're in the right place, because Depending on your trust, you might be expected to say whether or not this is within the stomach or it's gone in the wrong place. So the advantages of X-rays is that they're quite quick and easy to perform. That you just get the patient wheeled down to the department, and then they take an X-ray. Or if they're quite unwell and they need a chest X-ray, there's portable chest X-rays too. It's quite a low radiation dose depending on what you do, but pretty much all of them are quite low on the spectrum. And it's really good for looking at areas where there's a big difference in tissue densities. So this is typically like air and soft tissue, or bone and surrounding soft tissue. And as a result, that's why it's mainly used for chest X-rays and for MSK X-rays. There are lots of drawbacks, so there's quite limited information you can get, particularly spatial imaging, because it's essentially a 2D image of a 3D structure. So there are lots of superimposed structures, which means that it can be quite tricky to tell things apart or to tell where a lesion is. But we'll go through this, especially on the chest, in our second half. And then as a result, it's sort of changes can be quite difficult to pick up, and it's very reporter dependent. And because it's only a 2D representation of a 3D image, characterizing lesions can become quite tricky. Also beware of trauma. So often you can see fracture lines on X-ray, but as we'll find out, I think there's a slide on this later, it's often not perfect, and there are some issues, especially if clinically the patient's behaving in a certain way. Oh. Hang on, I think my slides froze. Oh yeah, so you can see here the importance of having two views. It can be quite commonly the case that you can't see a fracture on one view, but there'll be a lateral view which you can see the fracture line on. And this is just another example of why two views are important. So more of a clinical application, you can see on this frontal plain film with this ankle, it doesn't look like there's any bony abnormality, but then on this lateral ankle X-ray, you can see that there's a oblique fracture through the fibula. This is just the chest X-ray. You can see that there's consolidation in the right lower lobe. And then this is a hip X-ray. Does anyone know what this shows? Do you want to just type in the chat? Don't worry if you can't see it. So there's a yeah, well done. Yeah, so there's a like a discontinuity of the cortex here along the neck of the right femur. So it's also just worth mentioning fluoroscopy, which is essentially real-time X-ray imaging, real-time X-ray viewing. It can be diagnostic, it could be interventional, and depending on what trust you're in, a large portion of this will be done by the advanced practitioners. So where I work, especially, a lot of the vetting requests will go through the advanced practitioners. But for most interventional stuff, that'll go to a consultant. But the advanced practitioners in our trust are the first point of call for the vetting anyway. But if you're not sure, then just call the duty radiologist. This is a barium study. Does anyone know what this shows? Don't worry if you don't. So this is a dilated esophagus, and it tapers down to so close. It's yeah, it's achalasia. So it has this what people call a bird beak's appearance with the eye of faith. It looks like there's a bird beak here, and this is the rest of the bird. But yeah, so this is one of the quite common things you can see when patients come in with dysphagia and they have a barium swallow, and it can look like this. We'll go on to ultrasound. So ultrasound is a different kind of imaging. It uses high frequency sound waves to essentially fire into the patient, and then they get reflected back at the machine at the probe. And then depending on what gets reflected back, the machine turns this into a picture. Most of the vetting is done by the sonographers, at least it is in our trust anyway, but I imagine this is like that elsewhere as well. But it can be done by either sonographers, or it might get put onto a consultant or registrar list. There are loads of indications for ultrasound. It's really good for looking at soft tissue differentiation. And as a result, it's used quite a lot for looking at the neck, abdomen, pelvis, for vascular stuff, looking at the pleura, and for looking at soft tissues as well, for abscesses and stuff like that. And also, it's used really commonly for intervention, mainly for placing drains and doing aspirations or taking biopsies. There are loads of advantages. Once you buy the machine, it doesn't cost any more than that, apart from paying the whoever's going to do it. There's no radiation. There's little, if any, contraindications to doing ultrasound. The only contraindication I can think of is the patient's too unwell to come down to the department. And you can look at a load of different pathologies using ultrasound. It can be quite sensitive and specific too. It's really good for doing procedures. I think I've got a picture of that in a second. And it's a dynamic imaging, so you can look at things in real time. There are drawbacks, so it is very operator dependent. Patients who are quite large can be quite difficult to image, especially for things like abdominal ultrasound, because the soft tissues absorb so much of the ultrasound that none actually get through to the organs. And as a result, you can get quite limited information. And depending on what kind of patient you have, the image quality can be quite variable, especially with really unwell patients who are not very good at turning over. You can get quite suboptimal views. But you can rule in or rule out quite a lot of important pathology with ultrasound. Oh yeah, so I've just included this to remind myself that just be mindful about the kind of patient that you have when you request an ultrasound. If you have a really unwell, sickly patient who's, I don't know, scoring a News 12, they're probably not very appropriate to send down to the ultrasound department. Does anyone know what this shows? I appreciate that not many of you will have seen ultrasound abdomens before, but there are some letters on this to help you. Yeah, well done. So yeah, so this is the gallbladder here. I think this GB is given away, and all these hyperechoic blobs are gallstones. And you can see here, this is the common bile duct, which is measuring 1 centimeter, which is quite big. So this would suggest in the appropriate patient that there's probably a stone lodged somewhere downstream in the common bile duct, causing this to be dilated. So they'll probably have an element of intrahepatic duct dilatation and deranged LFTs. So they'll probably have a raised bilirubin. And then does anyone know what this shows? So this is the kidney, but does anyone know what's the pathology that we can see on this? So this is a kidney with quite a dilated system, and you can see on this bottom image, yeah, it's hydronephrosis. There's a stone lodged within the proximal ureter, and that's causing sort of backlog of all the fluid and resulting in hydronephrosis and hydroureter. This is just a picture showing that this patient's got ascites, and this is how we do ascitic taps and drains. So you can see the needle entering here, and we'll either aspirate through that, or we can place in a drain afterwards if the patient needs it. So going on to CT, so this essentially uses X-rays to generate cross-sectional imaging. You can see lots of pathology in quite deep within the patient that you can't see with conventional superficial imaging techniques, and you can use contrast in most cases to. There's a question: how are we orientating ourselves with these ultrasound images? So when you look at the probe, the way I imagine it is if you put the probe on a patient, so if you imagine that the probe is sort of facing down, the left of your probe should also be the left of the screen. And what you're looking is sort of looking through the sort of the fan of the ultrasound beams. It takes quite a lot of sort of practice at the start to get used to looking at ultrasound. And there's quite a steep learning curve, but after a bit, it becomes quite familiar. We've gone on about this already. So yeah, advantages of CT, as we all know, that you can see the organs really well. It's really fast. I think a CT head probably takes less than a second, maybe less than 2 seconds. And as a result, it's really good for imaging unwell patients, as well as looking at loads of different structures in the body. There is lots of disadvantages, however. There is radiation exposure. It's not that high per scan, but when you look at it on a population basis, we do loads and loads and loads of CTs nowadays. The risk of having a radiation-induced cancer isn't insignificant. And as a result, if we're doing loads of CT, there's quite a high workload for radiologists to report these as well. There are some risks of contrast, so some people can be allergic to it or have variable levels of reaction to contrast. And it's also not very good for differentiating between different soft tissue lesions. And because we're doing so much CT scanning nowadays, we're picking up loads of incidental findings which result in more workload down the line. This is just a CT of the abdomen. Does anyone know what this shows? Don't worry, I don't expect you to. I don't think I would have known in F1. Yeah, so these are loops of dilated small bowel. You can see here, so there's a dilated loop here, dilated loop here, dilated loop here. And you can see here, this dilated loop tapers down to collapsed bowel, and we call this a transition point. So yeah, you're right, it is bowel obstruction. So yeah, this is small bowel obstruction, and you can see the transition point here. This is probably due to adhesions. It's the most common cause of small bowel obstruction. And then we have a CTPA here. Does anyone know what this shows? Yeah, so this is the pulmonary trunk here. This is the left pulmonary artery, the right pulmonary artery, and we see that it should be full of contrast, but there's this large fill-in defect straddling the bifurcation. So this is a saddle embolus. Yeah, George, you're correct. We have another one here. I didn't realize I included so many. Does anyone know what this shows? This one's a bit trickier. So this one's a bit trickier. So this is the pancreas here. It's I've put 2 slides in because it's not horizontal across the body. So no, this is the liver. I think that's what you're probably calling pleural effusion. This is the liver, and this is the spleen, and this is the pancreas which drapes over. So it's on multiple different slides. So this is at one level, and this is at a slightly different level. So if you combine these two together, you can see the whole of the pancreas, and it's quite swollen, edematous, and there's loads of this, what we call fat stranding around it. So this is acute pancreatitis. Does anyone know what this shows? This is a CT head. Yeah, so this is an epidural or an extradural hematoma. And there's another finding. Can anyone spot that? So there's this lentiform sort of high density on the side. Yep, so hematoma. Yeah, there's a bit of midline shift, but there's one more finding which is most commonly associated with having extradural hematomas. Yeah, so there's a fracture of the skull on the temporal bone here. So someone's been probably collapsed over the side of the head and has caused this fracture, and as a result, they've got this extradural hematoma with midline shift. There's quite a lot of effacement of the gyri. You can't really see the gyri very well, so that's probably as a result of having loads of pressure in the head. So we'll quickly whiz through MRI. There are lots of pros and lots of cons of MRI, so it takes quite a long time to do a scan if anyone's had one before. But you do get quite high quality imaging, especially with the soft tissues. It's really important that the MRI safety questionnaire is completed because it's a really powerful magnet. And there's loads of indications. So neuroradiology use MRI all the time. It's also really good for looking at the spine. It's really good for MSK, looking between the ligaments, as well as looking for infection, occult fractures, and tumors. Cardiac MR is quite a big thing nowadays, looking for ischemia and looking for tumors, and GI use it as well for looking at the hepatobiliary system. Advantages, so it's non-radiating, there's good soft tissue contrast as we already said, but it's quite claustrophobic. I don't know if anyone's had an MRI, but you have to lie within a small tunnel for like a decent amount of time. But if you move at all, then the images are essentially not very good at all. So it's really important you have a suitable patient for this. A lot of metal work is contraindicated. It's worth checking with the MR radiographers if your patient has a compatible pacemaker or compatible metalwork or not, because some of them will be compatible, some of them won't be. This is just an MR lumbar spine. Does anyone know what this shows? Yeah, so this is S1 here, so this is L5, so this is L4. You can tell that this is L5 because if you look at the angle this vertebra is, and you look at the angle of the next one, there's quite a sort of sharp angle between them. So that's how you know this is L5 and F4, L5 and L4. And then there's this sort of defect here posterior to the intervertebral disc, and this is called the toothpaste sign. It's like when you squeeze out a tube of toothpaste. And this is causing impingement on the cauda equina. So yeah, this is cauda equina syndrome. And then I've just got another case on the right, which is, it highlights the importance of the MR looking for fractures. So this looks like a normal hip X-ray. But when you look at the MR of the same patient, you can see that there's a lot of low signal here. So this is a intertrochanteric right hip fracture that you can't see on the X-ray, but you can see on the MR. So this is where sort of clinical correlation is probably quite important. When you see the patient and they can't stand up or they can't move their leg because they're in so much pain, they probably have something going on. So just because the X-ray doesn't show anything, it doesn't mean they don't have anything. We'll quickly whiz through nuclear imaging. So this is using small amounts of radioactive substances to diagnose, monitor, and treat disease. Essentially, it's taken up an area of high metabolism, and as a result, we use this for bone scanning, cancer staging and monitoring. I'll show you some images of PET-CT, and we look at for myocardial perfusion as well. We get quite unique information from this because it's taking up a substance and you can scan it directly, and then you can overlay it onto CT to correlate it sort of spatially. And it provides a lot of important information for management planning, as well as looking for early malignancy or early metastasis of a known malignancy. But it can be quite non-specific. There can be areas of uptake where you're not sure why it's done that. It might be pathological, it might not be, and patients can be reactive to radioactive traces. So this is a sort of a PET-CT. The CT is lower quality because it's combined with the PET, but it doesn't look too bad at the moment. There's maybe this area of hyperdensity in the liver here, but when we look at the PET, we can see that there's a lot of avid uptake in this that suspected lesion in the liver, which shows that that's abnormal. And this is just another picture of a CT overlaid with PET. And it's not very obvious on this CT what's going on. There's some lymph nodes here which could be a bit prominent, but then on this PET scan you can see there's a lot of avid uptake on this paraortic lymph node, which implies that that's probably, in a patient with malignancy, that's probably a metastatic lymph node. So we'll go on to talk about requesting scans, because this is what you guys are probably the most interested in. So pretty much all scans are done, or they go through this order. So step one is you need to decide why you want the scan and what you think as the clinical team is the best modality. And this relies heavily upon what clinical information that you have and through discussions with your senior and with the duty radiologist. So once you decide that you want a scan of, let's say, a CTPA for a suspected PE, you'll fill in a request form, and this is either electronic or on paper. I'm pretty sure it's all electronic nowadays, unless you're in the middle of nowhere where they still use dinosaur systems. And then step three is the scan will then get vetted. In STA in Sheffield, where I work, the scans are all actually vetted by the radiologist automatically, so you don't often need to call us about it unless it's really urgent. We'll usually get around to vetting CT scans and vetting other kinds of scans. But if it's urgent, then you guys will end up calling us, and then we can discuss it over the phone. And then after it's vetted, the scan then gets booked. If it's really urgent, you can discuss this with the radiographers, but they usually sort this out themselves because they know what the other scans are happening in the department are, so they can prioritize them. And then once the patient's prepped and the porters bring them down, they get the scan, and then they then get reported by whoever's reporting the various CTs or MRIs that day. So we'll talk about putting in requests now. So it's really important to give concise clinical information, and some people use SBAR formats to hand over, and I found that that was quite an effective way to talk about scans when I was sort of before I did radiology, when I was requesting scans. There always has to be a clinical question, because without a clinical question, there's no point in doing the scan. And that can just be something like, is there a PE? Is there a collection? What's the cause of this patient's symptoms? And then when you have, once you've got a clinical question, you need to discuss with us what your differentials are, because there's a lot of context that needs to be had when we interpret scans. It's not as A plus B equals C. There can be a lot of grey area in interpreting scans. So knowing what your top differentials are and knowing the clinical context is really important, so that we can say what's more likely than something else. And then it's really important to know how the scan is going to change the management of the patient, because if it doesn't change anything, then there's not really any point doing the scan. And actually, you've just irradiated the patient for no point, because it hasn't changed anything. And then it's worth discussing over the phone so we can determine, is this the most appropriate modality to scan this patient? And we'll go through a case later on where it's a bit unclear if a CT, for example, is the best modality. And then you also need to consider patient factors too. So as I said earlier, there's no point requesting an ultrasound abdomen for an incredibly unwell patient, because they're not going to be able to tolerate the scan. And it's probably not going to be a very diagnostic ultrasound. It might be that a CT is better for that patient because it's really quick and you can get them in and out of the department. And as ever, if you're unsure, just call GT. So we'll talk about important information to include either in requests or when you're talking to us over the phone. So previous malignancy, knowing whether or not they've had previous cancer is really important, because there's a reasonable chance that the reason why they've presented in the current state is malignancy related. It could be due to progression of disease, or it could be due to disease sequelae like a bone mets, which is caused like spinal impingement, or PEs from known cancer, or other compression related pathologies. It's good to know if they've had this before. If someone's had a previous ischemic stroke and they've come in with new onset sudden weakness, they've probably had another stroke. Or if someone's had previous surgery and they've now got abdominal pain, it could be that they've got a small bowel obstruction from adhesions. It's not unlikely that you have repeat episodes of that. Knowing about previous surgery is important for what I've just mentioned, but also it provides a lot of information, like a patient with a previous hysterectomy and salpingo-oophorectomy probably won't have an ovarian torsion because it's been chopped out, but they might have adhesion of bowel obstruction, and that might be the cause for their acute abdomen. Looking at previous key imaging is important because nowadays, most patients have had a previous CT of some sort. So we can directly compare to the previous scan they've had a year ago, a month ago, a day ago, and see what change there's been since then. And it's really important to actually say, this sounds quite silly, but it's really important to know what side the patients or symptoms are on. It's quite common that patients have, the requests will just say abdo pain, query, renal colic, but it doesn't actually say what side the pain is on. So it helps us to localize pathology, and also it helps us to look for other differentials. So if a patient's got right iliac fossa pain, query, renal colic, we need to make sure they haven't also got appendicitis. It helps us to prioritize which scans are more urgent, because a lot of scans might not be that urgent. For example, a patient who's newly breathless, but they're having a CTPA to look for a PE, but they've already had treatment dosed dalteparin, is probably not as urgent as a different patient because they've already had treatment. So it will get done, and it doesn't mean that the scan's not important, but it does help us stratify which scans are more urgent than others. We've already talked about changing management, and it's really important that in certain patients that you've already discussed with the specialty if appropriate. And an example of this is for a patient with an acute abdomen, and it's probably more appropriate for this CT abdo-pelvis request to be coming from the surgeon, because if it shows anything, they're going to be the ones doing it. It's always a bit awkward if a patient has a CT abdomen and it shows that they've got ischemic bowel, and then we have to then tell the surgeons, but the surgeons don't know anything about the patient. So ideally, these kind of requests should come from the specialty if they're going to be doing something with it. They shouldn't really be getting you to request their scan. I've just included this just to remind myself to mention this. So a lot of the calls that we get on duty are for procedures, so placing ultrasound drains, doing aspirations. It's really important that these patients have an up-to-date set of bloods, including clotting, anticoags, knowing whether or not they're on anticoags at the moment, as well as recently, because these patients will often need to be bridged. It's good to know if they've had any previous imaging, and it's really important to know if they've been consented for the procedure as well. So when you're on the phone and you're about to discuss a scan with a duty radiologist, we'll go through a list of things that you should hopefully have prepared or have in front of you. And these include the patient's ID and name, because the first thing that we will ask for when we pick up the phone is going to be the patient's ID and name. So that means that we can get it up on our system, because any information before that will kind of get lost, because we want to be able to look at things as well as talking to you on the phone at the same time. You need to know the patient history, as well as recent bloods, investigations, and recent imaging. What the OBS like, as well as what the examination findings are, and what your management plan is, because it's quite easy to forget that you guys are the ones who've seen the patient. All we have is what you've included on the request form, and this can literally just be abdo pain query cause. So we'll know nothing about your patient, but you guys have seen them, you've examined them, you have the blood tests, so you guys know a lot more about these patients than we do. So these questions and conversations that we have with you on the phone is actually about us trying to find information to justify the scan, because we don't have access to the same information as you do quite a lot of the time. So we'll talk about why it's important. It's important because we need to make sure that they've got the correct modality for them being scanned. Because if they've had the wrong type of scan, they'll probably end up needing a repeat scan. And this will double the workload for the radiologist. It'll double the workload for the referring doctor, because they'll have to chase the report. It'll delay the treatment for the patient, and it'll also increase the radiation that they get. It's really important that we get the correct protocol, and this is why, because when we get a request for a CT head scan, we have to choose out of sort of all these different protocols which one we think is the most appropriate. And depending on which one we click, it will result in a different timing of the contrast. It might be just an arterial phase, it might be a venous phase. And this applies for not just head, but for abdomen, pelvis, and every single body system as well. So it helps us determine what the best protocol is for it, because some protocols are better for looking at some things than others. And it also helps us decide whether or not we need to do a contrast scan or not. It affects the interpretation of how we report it. So for a patient who you think's got appendicitis and we see lots of inflammation around the appendix, we'll probably say is appendicitis. But if you say that they've got known Crohn's disease and they've actually got lots of inflammation in the right iliac fossa and the terminal ileum looks a bit funny, then we'll probably say it's terminal ileitis due to Crohn's rather than non-specific cecal inflammation or appendicitis. As again, it helps us prioritize these scans. So we'll go through a few cases. So we'll go through each of these one by one, and we'll talk about how some of the information that you give will change how we vet these scans. So on our first case, we'll talk about a CTPA request. So there's a patient who's come in, they're a bit breathless, their inflammatory markers are neither here nor there, but they have a new oxygen requirement. So when we get a scan request, this can be all the information that we get, and it's very difficult quite often to justify doing a CTPA just based on this, because it could just be infection, it could be a pneumothorax. We don't know, like we don't have the patient in front of us, but you guys do. So it's really important that you guys include loads of information. So for this patient, when I call the ward team back, they tell me that the patient's actually been admitted for pneumonia, but they've been getting better quite recently, but now they're acutely unwell. They've got a chest x-ray which shows consolidation, but actually it's similar or probably a bit better than the previous one that they had. And they've done a Wells score, which is less than 3. So we need to consider other differentials here. Is it that a PE is most likely? Do they have positive Wells features? And I've got the Wells score here, just so you can see what ticks boxes. So if it's less than 4 or 4.5, then we'll need to do a D dimer. And this box here is really important because I think a lot of CTPAs get done unnecessarily because you've included PE in the consideration, but the PE actually has to be the #1 diagnosis or equally as likely for it to score this 3. And it's important to know what treatment they're on as well. So in this clinical request, we're actually missing quite a lot of information. We're missing the fact that they've got improving consolidation on a chest x-ray, that they've already completed a course of antibiotics, they've got a raised D-dimer, but they've also got a raised respiratory rate and heart rate, and they've got chest pain. So actually this patient probably does warrant a CTPA, and if this information is all included on the clinical request, then we can just vet it. There doesn't need to be a conversation to sort of delay the scan or to take you guys out of your busy day to do a phone call that you guys probably could have avoided. So our second one, we've got a 33-year-old lady. She's got right iliac fossa pain. She's vomiting. She's had a previous ovarian cyst, and the ward team have requested, or A&E have requested, a CT abdo-pelvis for query ovarian or abdominal pathology. So we need to firstly consider, is CT actually the best modality for looking at ovarian pathology? It's probably not. It's probably ultrasound. We need to have a bit more of a delve into the history. So we find out that actually she's got vomiting. She's had a 2-day history of worsening abdo pain. It's not sudden onset. And she's got a raised white cells and CRP, and she's ordering antibiotics for query appendicitis, and she might be for surgery. So actually the main differential here is probably appendicitis. So a CT is actually appropriate. It's good to know what the patient's like clinically. If she's peritonitic, it'll probably bump her up the queue. And is there any clinical indication towards other pathology? So, for example, the sudden acute severe pain, but not sudden, but worsening over 2 days, probably implies it's not torsion, because torsions are usually sudden onset, and they don't often always have the raised white cells and CRP yet. So we'll go for another CT abdo-pelvis or a chest abdo-pelvis request. So this is for someone who's generally unwell, they've got fevers, they've got abdo pain, they've also got a cough, they've got raised white cells, they've got raised CRP, and the ward team are wondering whether they might have pneumonia, or they might have some chest pathology, or they might have abdomen pathology, but they might also have cholecystitis. And these kind of requests are quite common, where the clinical details kind of include, it could be anything, and it doesn't really help us vet it that much, because For example, if this patient's got an abdominal collection, they need a CT of their abdomen and pelvis. But if they've just got a pneumonia, then a chest X-ray will be okay. But if they might have cholecystitis, then an ultrasound is probably the best. So when we call the team back, we find out that she's got previous cholecystitis. When we ask for a history, it turns out that she's got a couple of days of worsening right upper quadrant pain. It's colicky. She's now become unwell. She's Murphy's positive, so it could be biliary colic, but it could also be ascending cholangitis. But pneumonia is probably quite low on the list of differentials here. And it turns out that actually her cough is just a chronic cough due to reflux, so that puts pneumonia even further down the line. And then we've already talked about considering other modalities. So a third example is for a patient who's confused, query cause. This is a really common request that we get. And this patient's currently being treated as a UTI by the ward team. But when we call the ward team back, it turns out that she's actually had a history of recurrent falls at home. And this confusion is actually a gradual but quite recent confusion, but there's an acute decline in the confusion. And she's now got a fluctuating GCS. So you guys could probably work out what's happening without doing a CT head. This is important because there's two main different types of CT heads we can do. We can do a non-contrast, but we can also do a non-contrast with a bony reformat, so we can look for fractures. And in this patient, it's quite likely that she's had recurrent falls. She's probably got a subdural, and it's either now worsened or she's got a big subdural that's now causing some kind of mass effects, causing a fluctuating GCS. This is another kind of request that we get really commonly. It just says query stroke, and the ward team have just said that there's acute weakness. But when we call them back, it turns out she's had left-sided arm weakness, and it's a very acute history. It's only 2 hours. And the CTs in this context are mainly done just to rule out hemorrhagic stroke. It's good for looking at ischemic stroke, but it's not perfect. And a lot of patients can have a normal looking CT head, but still have an acute ischemic embolic stroke. So the role of these CT heads for the query stroke patients are essentially, if there's no hemorrhage, which we can rule out with a CT, because CT is very good for looking at blood, then this should be treated with a suspicion for acute embolic stroke whilst they're waiting for MRI, because MRI is the gold standard for looking for acute strokes. So as soon as we can rule out there's no bleed, then you guys can start on with the treatment, which is, I think it's still 2 weeks of high dose aspirin. But don't quote me on that. But the point is that once we rule out the hemorrhage, you can start the treatment, and then they can get the MRI in the near future to confirm. But a lot of places will thrombolize and do thrombectomy just based on the fact that they've got a very obvious stroke on clinical history and examination, and they've got no hemorrhage on their CT head scan. So that would meet criteria in thrombectomy centers. So that's how the role of a CT head plays in these patients. Another common one we get is an abdo X-ray for query obstruction or perforation. That's literally all it says. That's all it says in the request. But when we speak to the ward team, it turns out that 6 days, bowel's not opened. They've now got severe generalized abdo pain and vomiting. They've had a previous hysterectomy. And so we need to actually decide, is an abdo X-ray appropriate? It's not particularly sensitive or specific for obstruction or perforation. It might pick up a few. But to be honest, we need to think about how this is going to change the management, because if you have a high degree of suspicion for an obstruction, if the abdo X-ray doesn't show an obstruction, they'll need a CT anyway. But if the abdo X-ray does show an obstruction, they'll still need a CT. So it's quite unlikely for an abdo X-ray to change the patient's management. Abdo X-rays do have a role, and these are things like following up renal stones if they're seen on the CT localizer. But for looking for obstruction and perforation, you need to really be asking how this scan is going to change the patient's management. And then this is one that I had a couple of days ago. So the ward team requested an ultrasound for hematoma with no clinical context. And after getting a bit of a history from the ward team and looking at the patient's notes, it turns out this patient's had a hysterectomy and bilateral salpingo-oophorectomy 5 days ago. And she's now febrile, increasing abdominal pain, rising inflammatory markers, HB is stable. So we need to think about other modalities here, really. It's probably quite unlikely she's got a hematoma. It's more likely she's got a pelvic collection. And as a result, she probably doesn't need an ultrasound. She needs a CT abdomen pelvis with contrast. There's another request for a CT abdomen pelvis for query improving collection. Can the drain be removed? So this patient's currently being treated for a diverticular perforation with a collection. She's had a drain in for a number of days. And her inflammatory markers are all improving, her OBS are all improving, and her drain output has gradually reduced to 0. So what's the most likely explanation for this? Well, you probably don't need a scan to tell you that the collection is probably improving and it's probably resolved. So do we really need a CT for this? We probably don't. Oh, that's all the cases I've got. So before we move on to the second half, so today we've covered so far who is in the radiology department, what kind of services we can offer, the different indications, the advantages and the disadvantages for each scan modality, how to become an effective referrer, what kind of common imaging requests that we get, and how you guys can give us the best information so that we can together decide on what the best imaging modality is. I hope that helps. If there's any questions, feel free to email me. I won't take any now just because just in the interest of time, we should probably crack on to the second half and go through chest x-rays. But if you have any questions about interacting with GT radiology, or if you're interested in radiology at all and want to ask any questions, then feel free to email me. But otherwise, we'll crack on to the second half of the presentation. At the end of the next one, we'll send out a feedback form for you guys to fill in. It's really important that you guys do that because it helps us find out how we can improve this in the future, because we give this talk most years. But you'll also get a certificate to say that you've done 2 hours of sort of learning online, and you guys can put that in your portfolio as well. So bear with me while we load up the second presentation. Feel free to take like a minute or two to quickly go for a loo break if you need it. Can I just check you guys can all see this this PowerPoint that says chest X-ray teaching? Great, okay. So we'll give you a minute just to go to the loo, get a drink if you need to, and then we'll crack on quite promptly just so we don't drag on too late. Thanks.
Shall I start?
Yeah,
so thank you very much, Kev, for your great presentation. Hi, I'm Dimitri. I'm one of the radiology registrars in Sheffield. So I thought I'm going to present a chest X-ray teaching, quick kind of overview of common pathologies you might encounter, some teaching on anatomy, some common pathologies, and how to approach a chest X-ray. I by no means expect you to report them by yourself. Of course, if you have any questions or if you see those pathologies and you know what they are, definitely call us and we can talk through on the phone. So this is just an overview, like superimposed anatomy on the patient. We have left, we have right lung. So the right lung has two lobes. The left lung has two lobes. The right lung has three lobes, and they're all separated by those fissures. And here we can see how it looks on anterior, and here's the posterior view. As you see, there's a pleura just going quite down below the lungs, and this is where usually fluid collects. Can you guys hear me okay? Yeah. And this is just anatomy superimposed on chest x-ray. So we have here, we have trachea, we have great vessels of the heart in itself, lungs, again, the lobes, the oblique fissure here, horizontal fissure, and just a pleura just surrounding the lungs. You have the gastric bubble here, the ribs, all the skeleton. So all the structures, they usually have sharp borders, and it's something that it's called silhouette sign. So when you don't see those structures, when you don't see this hard border, when you don't see this diaphragm, and it's obscured, this means there's something either outside the lung or inside the lung that's causing it, and that's not normal. And this is how we're gonna look at how to approach the situation. So how do we take X-ray? So we have a tube, a source of X-ray, where we accelerate electrons, and when they accelerate themselves, they slow down, they hit the target, they release the X-rays, and these go through the patient. Usually for chest X-ray, you want them to go from posterior to anterior to get an accurate assessment of the heart size. They hit the grid, the receptors. So the ones that hit receptors, the image will look dark, and the ones that get absorbed into patient, you get white out. So they get processed, and we get the image of an X-ray. So how are we going to interpret this radiograph? Yes, this is difficult radiograph. Yes, I won't expect you to, to report it. But first of all, we want to look at the projection. We want to look at the technical factors. We want to look at clavicles equal, length apart from the spinous process. Is there any rotation? Is it AP or PA projection? We want to look at the demographic of the patient, the age, the history as well. Then we're looking for any foreign bodies, any lines or tubes. So here we can see NG tubes passing through. We have some chest drain here at the side. We have an endotracheal tube here in the trachea. We have a failed portacuff here in the axilla. Then we're looking at the heart and mediastinum. So we're looking at the highlight mediastinum. So we're looking at the heart shape. Is it enlarged? Is it normal? Is it displaced? In this case, we can see the heart is slightly displaced to the left. Then we're assessing the airways. We're assessing the lungs. We're assessing the pleura. So you can see the lungs, they do not look normal in this case. They have quite a bit of ossification in them. You have big pleural effusions here, which probably, if the stroma, probably some related to blood. So it's blood within the pleural spaces. We have some contusions within the lungs. Then we have to review the other areas, axillas. We have to look at the behind the heart, because sometimes you can have some consolidation, some masses sit behind the heart. You want to look underneath the diaphragm. You want to see diaphragm clearly on normal chest X-ray. Here we cannot, because there's probably a degree of collapse and consolidation. You want to look at the bones, and here we can see there's some rib fractures here. We can see some surgical emphysema. It's probably a little pneumothorax as well. Look at the soft tissue. Look at the breast shadows. All those sort of things. It's very difficult. It's to remember in one go, but with practice, you guys, if you have a step approach, you can actually pick up some stuff. So what do you think about this X-ray here? Is it normal, abnormal? So again, we're looking at the projections. Looks good. Looking at any foreign bodies, any objects, Exactly, it's normal. Airways, heart, lungs, everything clear. You have good vessels. You can clearly see the diaphragm on both sides. You can see the heart borders. You can see the hilar. You see the right one slightly below here than the left. You can remember it because right lung has 3 lobes, so it's not heavy, but you can think like it's a heavier lung, so it displaces a little bit inwards. And left one is slightly higher up, and that's important when you look at the X-rays, because any changes in the hilar will mean there could be changes in the lung volume. Looking at the bones, looking at the breast shadows, which you cannot really see here, and soft tissues. So this is normal X-ray. Now we're going to look for some common pathologies. So pneumonia, when you have respiratory symptoms of infection and you have consolidation on X-ray, means patient has pneumonia. So consolidation is when you get filling of the alveoli with fluid, pus, or blood, and you have these lucencies running through it, which are dilated bronchograms filled with air. So you have this opacification. This is whiteout in a blackout lung. And with those lucencies here, little dots. It's very difficult to appreciate. For example, here, if you can guys see this lucency. So this is consolidation. And silhouette sinus means I should not be seeing all of this. I should be seeing land markings. I should be seeing the hilar vessels, but I cannot. This means there's something obscuring it. Means there is some abnormality there, and in this case, this is consolidation. This is infection. Pleural effusions. So they formed in a pleural space. You can get fluid, again, pus or blood. Usually we do them in the kind of sit-up position, so you can get dependent collection of fluid. You're forming meniscus because water under tension forms a little bit of meniscus. So you can see this kind of concave shape. You have pleural effusions which are composed of fluid mostly. Those are transudates, and the one small which composed of proteins, so exudative. So exudative will be most like infection, malignancy, TB, and transudative effusion will be more related to fluid overload. And it's important also to know if they bilateral or unilateral, because unilateral effusions can be secondary to infection, malignancy, or perforation of the esophagus. Bilateral effusion can be due to fluid overload, can be due to infection, respiratory distress syndrome, nephrotic syndrome, a lot of different conditions. So when lungs usually aerated, it has air in it. If there is some obstruction to either inside the bronchi or to outside of bronchi, it's causing collapse of the lungs because the air cannot get through, so lung collapses and it's become white, like this, white out. So the anatomy changes. The hilar moves down, the fissure moves down, and you have this, as in this case, right lower lobe collapse, you have this sail sign, which is called. So you have smooth collapse here. You cannot visualize the diaphragm. This means the lung is collapsed, and the structures, there's a collapsed lung overlying the diaphragm. That's why you cannot see it. So you have this hazy appearance and displacement of hilar, the displacement of mediastinal structure to the side of the collapse. And again, it can be secondary to infection, tumor, or foreign bodies, and anything that compresses or impacts that airway. Pulmonary edema, usually majority of times you can see is people with heart failure, also people with respiratory distress syndrome and other conditions with fluid overload can develop this, or severe infection. In this case, this patient has quite significant fluid overload. Not a lot of pleural effusions, but you can have them. Curly B lines, I guess you heard of them. This means there's a fluid with an interstitium within the actual kind of lung tissues in between them, and they're forming little lines on the edge of the lung, usually at the bases. You have dilatation, you have of the venous system of the vessels in the upper zones because heart had to work extra. Heart is enlarged as well. So if the heart is bigger, then if heart is basically bigger than one side of the lung, basically from here to here, then it's cardiomegaly. So you can, if basically cardiothoracic ratio, more than basically half of it, it's called cardiomegaly. Pneumothorax is another common presentation. You want to trace the lung age, which you're usually not going to see here. And actually it's here, as you see, there's a whiteout, there's no lung markings. You want to make sure there's no tension, because if there's a tension pneumothorax is when you have this establishment of one-way valve. So the air gets into pleural cavity and it cannot escape. It's pushing on the lungs and pushing on the great vessels and causing the arrest. The patient goes into arrest. So in this case, you want to get a cannula, a needle, and go into second intercostal space mid-clavicular line, and just decompress this. They do not need chest X-ray at this point because they're probably going to die by the time they arrive in our department, and we are not the best at dealing with it. Here we have example. Here we have another X-ray. Normal, abnormal. I just want you to see as many as possible. The more you remember, want to see some normals. Is it normal? Again, looking at the shape of the lungs, any foreign bodies, heart, pleura, bones, soft tissues, breast shadows, under the diaphragm, behind the heart, axilla, apices. That's normal. Hyperinflated. This is normal. I know, I think this patient just took probably a deep breath. So what do we have here? Patient presented with shortness of breath, let's say. We do an X-ray. Is it worrying or not worrying? See dextrocardia. And you're also suggesting worrying. George think it's worrying. I agree. So again, we're looking at the lungs. We're looking at any position of the X-ray is great. There's no foreign bodies. Now we're looking at mediastinum and heart. So we cannot see right heart border. The hilar is enlarged. Yes, there's a right hilar mass. And yes, so in this case, there's likely to be some kind of malignancy. Hilar mass, if we're thinking about lymphoma, lung cancer around that area, yes. So this patient will need to have a CT staging scan to assess this and look for any metastasis. What do we have here? Perihal lymph node, widened mediastinum. Yes, yes, mediastinum is widened. It's widened because there's a mass there in the mediastinum. So all of this, you see, you should not have this here, and this is massive mass just obscuring this. And this is in anterior mediastinum. You cannot see the heart very well. You cannot see sternum kind of very well. So it doesn't go above the clavicle, so it's not in posterior. So it's anterior mediastinal mass. Do you guys have any idea what this could be? Anterior mediastinal mass? like some differentials. Sarcoidosis. So sarcoidosis will cause you bilateral lymphadenopathy, more at the hilar, more in these regions, and more lung changes. This is kind of isolated appearance of the large mass. Aortic dissection is a good shout, but that will be in a middle, more kind of middle to posterior mediastinum, where aorta. We cannot see aorta here visualized very well. I believe it's still there. You cannot very appreciate probably on this X-ray. Thymoma, yes. So thymoma, lymphoma, germ cell tumors, or thyroid goiter. So it's a TTs, terrible lymphoma, thymoma, teratoma, and thyroid goiter. That's anterior mediastinal masses. What do we have here? So you see it's kind of the same theme, similar theme. This patient's been admitted to hospital last year, where he was very unwell and had a collapse. Okay, yes, that's close. That's right. So he has aortic stent here, and this you have here. You have this mass, and this is mass is an aneurysm basically that arises from this aorta during when he had dissection, had stent put in. So again, it's important to see those things because these do not look normal. And if you see this at night or on a weekend, probably worth giving radiology a call because sometimes X-rays not get reported every day. This is more difficult, but if you look at the heart, look at the lungs, look at the soft tissues, you can have a look. How to differentiate posterior and anterior mass? So anterior structures, that's a more hard border, kind of more hilar regions, they will be obscured. In posterior structures, the vertebra, the kind of aortic arch, descending aorta, but more vertebra, posterior ribs, they will be obscured. Metastasis, yes, very good. But what do you think is like primary cancer here? Think comparing side by side. They're a bit different side by side. Kidney, liver, good shouts. Breast, yes, exactly. So we see there has been previous mastectomy, and this is cancer recurrence. So it's all breast metastasis, and they all look like breasts. They all circular nodules, masses, and you have the hilar lymphadenopathy here, and this is typical breast recurrence. Well done. What do we have here? Somebody said it earlier. TB looks very awkward on X-ray. TB, there's different TBs, primary and latent TBs. TB can look in the primary as consolidation, and later you develop some calcified lymphadenopathy and nodularity. So I would not include it on this case because sometimes even radiologists struggle to differentiate TBs from other conditions. Cannonball meds, yes, cannonball meds. So in a patient, in RCC, testicular cancer, colorectal cancer, those most common things. So when you see that, okay, we need to examine patient's testicles or do a renal ultrasound. So here we're going into another themes, moving from tumors. And what do you think this could be here? COPD, having someone saying COPD. Yeah, lungs kind of distended. Right side opacification, yes, correct, George, lower zone. So in here we have this air bronchograms here. You can see it. Maybe you cannot appreciate it very well on your screens. Sometimes it doesn't project very well. But yeah, this is consolidation. Usually in radiology we refer on the most X-rays in zones and not lobes. But here I can say there's some overshadowing of the diaphragm. I'll say this right lower lobe consolidation. What do we have here? Consolidation, and tell me the area. Where do you think it is? Yes, correct. Next case. Yeah. You can see some shadowing behind the heart, although it's not very clear. It's difficult because sometimes you do have some vessels and airways are going through it. You usually have to window X-ray, but here we have opacification that obscuring a right heart border. Yeah, with air bronchograms. So this must be in the middle lobe. That's right middle lobe consolidation. So I wanted to show different areas of how consolidation looks, so you're comfortable on what infection looks like, or any other causes of consolidation. And what do we have on this X-ray? Sorry, this one is a bit of bad quality, but it has quite a few interesting signs. Effusion, someone saying? So effusion you can have effusion if patient kind of laying down hemi flat, and it can spread around the lung, so your lung will look a little bit more pacified. So yes, that can be differential. Consolidation, left-sided blunting. Yeah, that's correct. So this is just a very lucent lung high penetration X-ray. So in this case, I can say there's a consolidation of this mid-lower zone on the left, and you cannot see behind the heart, and you cannot see the diaphragm. There's some degree of collapse of the left lower lobe as well. So two pathologies, and they usually goes hand to hand, and there is a mucus impaction and infection. And what do you see here? Right pleural effusion. Yeah, that's correct. That's right. Yeah. So you can see this effusion collects independent portion. Not sure if there's infusion here on the left, but for effusion to present on X-ray, you need at least 200 or 500 mils of fluid to present there already for it to show up on X-ray. So it's quite a lot. So yeah, you can see this you cannot see the diaphragm. You can see meniscus sign, and yeah, this is effusion. This could be infection. It could be malignancy. Heart failure is a common one to present with right-sided pleural effusion. So a lot of differentials to consider here. What do we have here? If I'm going too fast, can you just let me know? I'll slow down, give more time on each radiograph. Hard to see. Yeah, exactly. That's correct. Right hemidiaphragm is low. Okay, so yes, pulmonary edema, correct. So this is typical fluid overload. So we have pleural effusions here, bilateral. We cannot see the heart, but I bet it's enlarged. We have little lines here, if you can appreciate them. This is curly B lines. Curly B lines. You have increased lung markings, which means there's a lot of stress in the lungs. And increased venous diversions here, more vessels going up. So the increased stress on the heart. So this is fluid overload, probably likely to heart failure in this case. Yeah, well done. What do we have here? Pneumothorax, nice. You guys good. Yeah, again, looking at the lung markings, missing. Oh wait, they're here, and all this lung is loosened. Yeah, so massive, big pneumothorax. Not so much of mediastinal shape, so you're not really worried about tension, but keep that in mind if patients start deteriorating. Yeah. What do we have here? Pericardial effusion, cardiomegaly. Good shout on pericardial effusion, but I'll explain to you why it's probably not pericardial effusion here. Yes, it's really big heart. You can see this line here. This is called double heart border. You shouldn't see this. This is right atrial border, and this is left atrial border. So left atrium is enlarged. Usually it's here, sits here, and it's spread. So it's now left heart failure. Now it's total failure of the heart. So it's enlarges. It's a big heart. Not much of a changes in the lungs, but um, it probably will have to. So yeah, this patient has a heart failure. With a pericardial effusion, you'll have uniform increase of the heart, and sometimes it's very difficult to is tamponade. Tamponade will be more likely clinical diagnosis, where the patient will be very unwell. In this case, it's just enlarged heart. Flood diaphragm borders indicate hyperinflation. Um, no, it's just sometimes you can have a deep breath and you have flat diaphragm. In patients with emphysema, the diaphragm can get quite flat. Um, that's like textbook knowledge. You can have flat diaphragm and secondary to emphysema. Sometimes young people can have a very, very good breath and the lung will expand quite a lot. People with asthma can have quite expanded lungs and have a flat diaphragm. So yeah, there's a lot of different diagnoses for flat diaphragm. It can be normal people or people with some abnormalities. Thank you. And what do we have here? Right upper lobe collapse. Well done. Yeah, very good. So we have this horizontal fissure that's moved up, and this is opacity. Yeah. So there's a reduced volume on the right side compared to the left. Not slight tracheal deviation to the right, you can see here, because of the volume loss. And this opacification is collapsed lobe. Yeah. In this case, we need to worry what this is. This patient needs to have urgent CT to look for infection or look for malignancy, because otherwise, why would they would not just suddenly develop this condition? So here you have normal position of the right upper lobe, and then it moves kind of anterior medially and collapses here. What do you see here? Raised semi-diaphragm, yeah, correct. Midline shift to the right. Yep, yes, there is. Tracheal deviation, correct. Raised hemidiaphragm, close, but slightly, a little bit different. There's something else that's going on here. I don't think you can see the diaphragm here very well. Collapse right-sided. Which one? What lobe? This collapse. But what collapsed? It's called sail sign because it's like a little sail on the boat. Yeah. So it's collapse of the right lower lobe, and this is typical location and the way it looks. So you see you cannot see lower lobe very well on AP, but here's all of the lower lobe on the lateral projection, and it moves a kind of inferiorly medially like this to create the sharp line. And you can see it as you cannot visualize diaphragm very well, and it's a smooth sharp line, and this is what right lower lobe collapse looks like. What do we have here? Some cases I will be repeating throughout, so for you just to get experience. And the more cases you see, the better you become, and that's for in any radiology subspecialty. Right, pneumothorax, correct, George. Yep, you can see the lung marking here. There's no lung markings throughout this, in between the ribs. You see there's no lung markings, so this is just air, the gas. Yep. And you can see where it spreads down. You see the pleural space. You see all of this is air. This is more difficult. This is very subtle. I hope it projects well on your screen, otherwise it's difficult to appreciate. But this is a difficult case. I just wanted to show that sometimes things cannot get picked up properly, or things get picked up because of things like this. So this patient has cough. Rib fractures. No, there's no rib fractures, no. Large pulmonary vessels. I think pulmonary vessel is abnormal. You can see pulmonary vessels like little finger here going down. Tracheal deviation, yes, slightly, little bit, yeah. Right lower lobe consolidation. So yeah, so you can have a little bit of consolidation, but what we cannot see here, we cannot see the right heart border very well, and middle lobe, right middle lobe is right next to it. So we need to think about whether it's consolidation or is it a collapse. Now, if you sit a little bit far away, you can appreciate that this lung is more loosened than this lung. It's because this one has a collapse. It has a little bit reduced volume. So you have right middle lobe collapse here. It takes quite a lot of space actually. So when it collapses, it creates a shadowing across diagonally. So you can see all this shadowing here, and you cannot visualize the right heart border. This is more difficult, but if it's spotted on X-rays, then patient will have a CT where they might find a cancer. So sometimes things like this get missed, and yeah, it's important to spot this abnormality and to visualize the heart very well. And if you cannot, this means there's something going on there. What do we have here? There's a theme of condition that's happening here, kind of make the learning a little bit more efficient here. I do try occasionally trick you, but I won't. Yeah. Again, we're looking at any foreign objects, looking at mediastinum, looking at the heart, looking at the lungs. Is there any changes in lung volume, any mediastinal shift? Can you see the heart very well? And then you need to figure out what is the diagnosis here. Unable to see the heart. Exactly, yeah, you cannot see the heart. So let's go through it a little bit. It's a little bit more difficult here. So rotation-wise, X-ray looks good. Penetration-wise, it's also good. Widespread ossification on the left. Exactly, the left side is ossified compared to the right. Yeah. The volume loss, look at the diaphragm. You shouldn't have left diaphragm higher than the right. Right underneath the right diaphragm there is a lever, so usually you'll have right diaphragm higher, but not the left. So in this case, we have volume loss in the lung. We have Hylar vessels here. Again, they should not be that high. Here we have Hylar vessels. Difficult to see here, but if you see my markers, and we have them here. So the lung is moved. For lung to move, there needs to be change in volume of the lung, so the lung has collapsed. And this presentation is typical for right upper lobe collapse. Because right upper lobe is a big lobe here, and it spans the lung completely, kind of vertically. So when you have a lung collapse, it goes kind of anteriorly, and it creates all the shadowing. And you have the hyperexpansion of the lower lobe, which you can sometimes see the lucency around the aortic arch, like here, which is called a Lufsichel sign. You'll not see it very well here, but maybe there's a case coming where you can appreciate it better. What do we have here? Someone wrote right lower lobe collapse. It's earlier. Okay. In this case, you want to look at the review areas. So review areas will be diaphragm, behind the heart, axilla, apices. Because the lung looks relatively normal. The heart looks kind of okay shape. Mediastinal mass, yes, it could be mediastinal mass. The heart looks enlarged. I would say it's not more than half of this length, so it probably fits within one side of the lung. Lungs hyperinflated. Yeah, not in this case. So you cannot see the vessels behind the heart. You cannot see the left hemidiaphragm. This means there's something going on. And you can see this line going through here. This is ossification of the lung. So this is a left lower lobe collapse. So this lobe shifts down and medially and creating this picture here. So you cannot see the behind the heart. So sometimes it's very important review areas to see. You cannot see behind the heart. You have a cell sign, and you cannot see the diaphragm. So this is kind of definition of this collapse of the left lower lobe. What do we have in this X-ray? Large body habitus, yes, large. Large heart. Okay. So at least you're seeing the abnormality. Widened mediastinum. Yeah. So now we're looking at the other review area, which I talked earlier, which is looking underneath the diaphragm. So looking underneath the diaphragm, we should see some bowel. We should see some. What should we see here? Underneath the diaphragm, underneath left hemidiaphragm. What usually sits here? Gastric bubble, yes, and you see gastric bubble is here now. It's a large hiatus hernia in stomach. And yeah, this sometimes can be very confusing because it's going to press on the lung. It's going to cause atelectasis. There's going to be reflux. They're going to have some pneumonia, some aspiration pneumonia because of that. and you can see the heart is behind it, see here, but all of this is basically your stomach sitting in your chest. Yeah, nasty. This is pediatric radiograph. I included some pediatrics because I know most of you probably not going to experience much pediatrics over your foundation training, but it's good to see them. And if you do work in pediatric hospital, you're probably going to be supernumerary, but it's still, I think it still can be interesting because they do have some wonderful conditions that present in radiology. Diaphragmatic hernia, yeah, that's correct. Well done. So here we can see there's a kind of a shift mediastinum of the heart to the right. Yeah, this structure here is a thymus. You can see it's in kids. That's normal. But there's a shift to the right because there's an increased content within the left lung, and all of these lucencies. This is bowel. Yes, this is bowel in the thoracic cavity because of the hernia. So you have Bogdelic, you have Morgagni hernias. So it's quite large. You cannot even see the diaphragm. So when you cannot see the diaphragm, this means there's a large hernia. And with the cystic lucencies, you can say this is diaphragmatic hernia containing bowel. If you can see diaphragm very well, then you're more looking at some congenital conditions such as pulmonary malformations. You have looking at duplication cysts, all other fancy conditions that radiologists will be trying to interpret. But in this case, this is diaphragmatic hernia. Patients can have a fluoroscopy scan where they put NG tube down. They can either fill it with contrast or with gas, and you will see increase of the lucencies or contrast flowing through them. Usually with gas, with air, we'll fill it, and you will see better. This need to be repaired because they can develop hypoplastic lung, and the lung will not function very well. What do we have here? Nice, pneumoperitoneum, exactly. Yeah, peptic perforation, any viscous perforation can cause that. A lot of some different diagnoses, post-operation, post-surgery, even patient with severe COPD or conditions can actually sometimes cause some gas, but not as much. So yeah, this is worrying. This is worrying. There's a gas under the diaphragm. Sometimes it's a continuous sign. Sometimes it's flowing from one to another. You need to make sure it's not a bowel. You have sometimes a bowel overlying it, but this is definitely flowing through it, a gas, dangerous, some kind of viscous perforation if they not had recent surgery. With recent surgery, yeah, that's normal. It should slowly reduce in the next few days. But if you have patient with abdominal pain, you touch the tummy, it's very tender, you do X-ray, perforation, they'll probably need to go to theater quite urgently or have CT done at the table at that time. And what do we have here? Again, looking at the airways, looking at the shapes, looking at the soft tissue. So looking at soft tissues will be quite useful here because, oh yeah, well done, well done. Yeah, so you can see this pericardium is kind of shifted a little bit, and there's a gas, and the gas is tracking up. There's all loosened streaks in the neck. It shouldn't be there. So this is pneumomediastinum. It's when gas escaped into it. So there's some kind of fistulation that's going on between lungs and mediastinum. People, do you know what conditions in young people this is most common? Which respiratory condition? Yes, so fistula is correct. That's the one. Asthma is the one. Yes, so asthma, people with asthma can develop this. Esophageal perforation, fistulas, yes. Before I've seen cases of people on concerts just singing and they had asthma and they managed to develop this. So yes, it's not a nice condition. It can spread. You can spread into subcutaneous emphysema. You can develop. It spread anywhere. Yeah, it's not a great thing to have. And what do we have here? This is something similar. I mean, you've seen it before in this presentation. Yes, there's a tracheal deviation. What do you think is happening there? Left upper lobe consolidation, very close. Very close. So you can see the opacity in the left upper zone, yes? Tracheal deviation. There's no pneumothorax. This lung is just loosened this projection. And there's a collapse. Yes, there's collapse, there's volume loss. So you think, yes, okay, you might think this is dissection, but this is aortic contour, yeah? And this is loosened line is important, which I mentioned before, but it wasn't very clear. So this is a left upper lobe collapse again, and you can see this dilated. This is gas here. This is air. This is dilated left lower lobe against the aorta. So it creates this. It creates this sickle sign. So when you see this, you see volume loss. You see widespread opacification with a shift in the mediastinum to the left. You straight away need to think this is left upper lobe collapse, and patient need to have CT because they probably have some cancer going on there. What do you think this is? Foreign body. Well done. Very good. Again, so you see this screw impacted in the left main bronchus, causing the complete collapse of the lung, yeah? Causing the complete collapse of the lung. And this need to be fished out. Too easy, guys. Screw the slide. Next one. What do you think here? This is just more sort of showing you different foreign bodies, different objects that can be seen on the X-ray. So this patient has a pacemaker. Yes, exactly. Normal pacemaker. Actually, ICD. Yeah, will be quite thickened. So yeah, you want to look at the all wires. If there's any fracture, if there's a dislodgement of this, but that's okay. You also want to see if there's a pneumothorax. Yes, that's probably more important. If there's a pneumothorax after chest X-ray insertion, that can happen. You want to rule it out after pacemaker insertions. What do we have here? This is it looks a bit of low quality here on my screen, probably worse on yours, but if you can see it and say it's normal or abnormal. Right. Very difficult to see. All right, yeah. So this is NG tube. Yes, NG tube insertion. So with NG tube, you want NG tube to pass. Yeah. So this basically, yeah. Sorry about this one, but I didn't expect it to project so badly. So you see this NG tube. It should pass straight past the diaphragm, past the carina here in the midline, through the diaphragm here into the stomach, and you can need to see the tip. So this is a normal position of the NG tube. You want NG tube to be positioned from this point, which is gastroesophageal junction, to this at least 7 to 10 centimeters. Also depends where the holes are. You don't want the hole to be here or here in the esophagus because it's going to cause reflux and you get the patient going to develop aspiration pneumonia. You don't want tube to be anywhere else, here, or there, or out of the patient's nose. Yeah, it happens. It goes one way, it comes out of the second nostril. You want it to be in the stomach. What do you think about this X-ray? And what would you do? Remove. Yeah, exactly. Remove NG tubes in the right lung. Yeah, don't feed them. Remove it, and try to replace it and X-ray again. And this has been removed and placed now, correctly positioned. But as you see now, there's some consolidation. Yes, they have given them some food or some fluid, unfortunately. Yeah, you have to treat that now. And here, what do you think about this NG tubes? Correct position, incorrect? You can probably, so let me follow it for you. Here is it. And here we have, this is just a tube outside. And this is NG tube here. Yep, so this is in correct position. What do we have here? Was ICD part of heart failure? Probably more of arrhythmias and where it needs to be treated. The heart rhythm. Surgical staples. Yeah, so there have been previous sternotomy. You can see cabbage here, the clips, little clips here, cabbage. But most importantly, NG tube. NG tube is not in properly. So this need to be removed and tried. Well, it can be pushed a little bit forward, to be honest, and then re-X-rayed again. So yes, don't feed them. Consolidation. This is breast shadows here. Not consolidation. It's on both sides. It kind of runs here. You can see as a contour of the breasts. So this is breast shadows. The lungs are clear. Even here you have sternum going on. So sometimes you might think, oh, it's something here. But because X-ray a little bit rotated, you manage to get through some of the bone. So you need sometimes a perfect alignment. You need to look fully. This is not great X-ray. This is quite difficult. This is sometimes what we get on call. Lots of different lines, tubes, bad quality X-ray. Because they have all clothing around on them. Yeah, not great. Tubes not being removed. So do you know what this is? It's a central catheter. It's a PICC line, and it usually have to sit at junction between vena cava and atrium, so atrial junction here. You don't want to go too far. You don't want to go too high. You don't want to go in other places. And G tube, you can also see here. It's not in the right place as well. This is some ECG wires. Patient also has fluid overload. You cannot see the lungs very well. They all kind of have this opacification. So I need to give them some furosemide as well. What do we have here? Again, NG tube, yes, NG tube in the wrong position. So you can see it's gone into the right main bronchus, coiled, went into the left on the left side, in the left bronchus, and you see it's causing collapse of the lungs. Again, you cannot see the diaphragm very well. There's a consolidation and even some fluid here. So yeah, this patient probably experiencing some collapse, some aspiration. So this need to be removed urgently. What do you think happening on this chest radiograph? I want to illustrate this line. This is a PIC line. And again, do you think it's in position correctly or incorrectly? Too short. Not in atria. So it doesn't have to be in atria. It has to be just in a kind of vena cava here, not in the atrium, just in the caviatrial junction. If they go into atrium, they can cause some arrhythmias. There's some catheter you want to be in the atrium, but with these peripheral small like a caliber catheters, you want them to sit just here to here. So it's probably in correct position, just there. What do you think this patient has? What condition? Let's say they need frequent antibiotics treatment and some sort of steroids. There's a bilateral changes throughout the lungs. The lung look very coarse. I'll tell you this patient is young. Cystic fibrosis, yes, well done. So this is cystic fibrosis. Cystic fibrosis shows you some cystic changes like this throughout the lungs and some fibrosis, hence the name. Yeah. So you have lung looks very coarse. There's a lot of architectural disturbance throughout the lungs. They can change shapes. You can have masses there secondary to fibrosis, and you have these lucencies which secondary to kind of bronchiectasis and impaction and dilatation of. So this is cystic fibrosis, and patient is receiving some treatment for it. And here's a line. And what do you think here? Difficult to see this one, but most of them are usually difficult to see. Left-sided fluid diffusion. Yeah, I know what you mean. Yes, this area is particularly difficult sometimes because you have a fat pad, that pericardial fat pad that runs here and makes this area looks like there's a fusion or consolidation. So this is actually just a pericardial fat pad. And the more you see them, the more confident you become knowing it's a fat pad and not something else. But good spot, good spot. So here we have a PIC line that is going through. And it's going to the neck, it's going up jugular. And it shouldn't go there. You need to remove it and it should go here. Here we go. Incorrectly positioned PIC line. So there's a theme, yeah? What do you think about this one? Yeah, well done. Yeah, so PIC line goes up, vein, probably cephalic brachial vein, going up axillary vein, and it's curled itself. So yes, again, need to be removed. Well done. Well done. Here's it. Do you know what this is called? PIC line on the right. Yeah, that's PIC line on the previous one. Yeah. And what do you think about this one? What type of patient do you think this is? So this is basically dialysis tube. Yes, large tube patient uses for dialysis for large volume. It goes right into kind of right atrium here with a tip. So that's quite common. And you can see here there's some poor visualization of the diaphragm, probably a little bit of consolidation. What do we have here? This is a little bit more difficult. You need to pay attention on the lines and tubes and tell me what's wrong going on, what's wrong with tubes, and then you look at the lungs and tell me what's wrong with the lung and why. I'll give you a little bit of time for this one. ET tube, yes, that's right. There is it ET tube, yeah. Too far, well done, very good. So yes, so ET tube is basically pushed into the right lung. This means we only give oxygen supply, aerate the right lung. So left lung doesn't get any oxygen, it collapses, yes? So you can see there's a little shift. ECG, heart monitoring leads, yes, tube in the lung. Yeah, so this is ET tube, so it's a patient, probably in ICU, they cannot breathe properly. So they need, it needs to be about 5 centimeters from the carina here, and it's going too far, and it's causing this collapse. So need to be retracted back. And correctly spotted, NG tube is not in as well. Yes, George, well done. What do you think happening here? And if you know the structure. Yes, portocuff, correct. This is portocuff. You just put them under the skin, and they have this kind of jelly plastic flesh under the skin, so they can get frequent injections into it, so it can stay there, and it's more safer than any cannula or PICC line that stick outside. This is for long-term treatment of condition. And what do you think this patient has? What condition? This is bad. This is a bad case of cystic fibrosis. Yes, correct. What do we have here? This is baby. You went to shop and you can't find your coin, yeah, to pay for your cigarettes, yeah. And you look at the baby and your baby is choking. Wow. You take him to hospital. You see this, and there's a coin. But this time, what's happening here? This is another baby. Foreign body, yes. What do you think this is? Exactly. This time he went for your battery from your remote, not for your coins. So this is how it looks. It looks like circle in a circle in the battery, and it looks a little bit like this on the lateral. So these are very dangerous. So coin can pass through, battery can pass through as well, but lithium battery will cause quite extensive reactions, so they need to be removed urgently. You also need to pay attention where it's stuck. Is it in esophagus or is it in trachea? Because the way it's positioned, if it faces you, most likely in esophagus. If it faces away from you flat, most likely in trachea. It's the way it expands. Trachea will expand anterior to posteriorly. Esophagus will expand more side to side. So here we see it, both of them lodged in likely esophagus, and you can see trachea here. So this patient swallowed them, or if they inhaled it, or it's more dangerous. Of course, they will be choking, and it can cause quite severe reaction. You can see vocal cords, what they look like normally, and this is what it looks after a few hours after the battery being in. So this is emergency. So I didn't include many pediatrics films, but I think if you see this, yes, that's correct, battery cause erosions. Yeah, if you see the battery, and you can differentiate battery by this double circular border from coin, you can save their lives, because this is emergency. Battery, a coin, you can probably leave it, see if it's passes, or you can fish it out, but this is emergency. This need to be removed. Magnets is another but quite dangerous thing. Getting two magnets swallowed, they can basically pass. They can connect themselves on different part of the bowel, and basically cause bowel ischemia and perforation. So yes, all foreign bodies quite important to rule out. Do X-rays on them. Quite few, just few more, just common conditions. Just type it in. What do you think here? Effusion, yeah, large effusion. Again, different diagnosis, and now you know there could be underlying collapse as well. We cannot rule it out. Usually, you have effusion and you have compressive atelectasis collapse on the lung. They occur hand to hand. Again, infection, heart failure, malignancy. We cannot see it on X-ray. Probably do. We probably will repeat this X-ray after treatment in a few weeks, or if it doesn't resolve, do CT. All also depend on the clinical findings. Does this patient have inflammatory markers, or they have weight loss, or they have evidence of heart failure? What do we have here? Nice, very big heart, cardiomegaly, coarse lungs, increased interstitial markings, curly B lines. This is heart failure. Yes, well done. Very good. Increased lung markings, right heart strain. Yes, correct. Curly B lines in the previous X-ray. Yeah, I'll have to go back quite a few slides. It's difficult to see. Here's the horizontal white lines going through the periphery of the pleura, like this. The small lines, they usually at the lung bases. You can see some here, maybe. Not a great one, probably not projected very well. You can see them very well on CT. They just go throughout, lots of lines throughout, like a web. And here on X-ray, we just see them little lines like this. What do we have here? Yeah, tracheal deviation, very good. You're going systematically, white out, excellent. So you have tracheal deviation to the contralateral side from the white out, yes? So if you had collapse, you have volume loss. It will be going opposite side, yeah? It will be going into it. So if there's a deviation of trachea from away from the side, this means there's an increased volume at that side. Effusion, yeah, this is very large effusion. Very large effusion. You cannot see the heart at all. You cannot see all the structures. There is a mediastinal shift. There is some consolidation even going on here. So in this case, you need to worry: is this infective? Is this malignant? They probably requires ultrasound guided tap or drainage as well. They probably work. Probably do X-ray, do CT to check for any malignancy underlying, and then do ultrasound tap. to make sure it's not infection. What do we have here? This is poorly rotated X-ray. There is a lot of lines. So it's rotated a lot. You cannot see very well. A lot of lines going on. So ET tube, central venous catheter, lots of ECG leads. Yeah. This thin clip on the right side. This clip, it's probably something external in the pocket. I think actually this is probably patient's chain, because you can see this little thing is probably related to patients have some kind of necklace. And there is a right pneumothorax. Yes, that's correct. You can see the edge of the lung here and white out. And this lung collapses and forming this shape, as you see. What do we have here? Third rib. Let me just go back, sorry. Third rib. 1, 2, 3. You mean this? Yeah, it's probably necklace. External. One up. This is tubing, oxygen tubing. You see this little what do you call it? Spring and connection. This again, this is external. Patient has some oxygen into the ET tube. What do we have here? And what would you do? To be honest, if this is done in our department, yes, it's probably I'll be dealing with this and not you. Exactly, very large. This is tension pneumothorax. This is massive tension pneumothorax. This is diaphragm shifted. This is collapsed lung, all shifted to the side. You see there's lots of chest drains. This is probably unwell patients. You can see they have ET tube, catheter. So they're gonna come. These patients will come with anesthetists, with full team, and they will see this and they will decompress it right on site. But it's a good example to have, and you might have something similar like shifting the structures. And yeah, if you there with patient, you can get involved and decompress this. So second, intercostal space anteriorly, mid-clavicular line. So 1, 1, 2 here, mid-clavicular line in this space. You will go with a large cannula. What do we have here? Left pneumothorax, no mediastinal shift. Yeah, it's correct. Not just this is probably not going to cause much of mediastinal shift, but also you need to worry and watch out. So there's pneumothorax, but there's something else. Correct. It's flat diaphragm. What do you think this is? So this patient had trauma, or some kind of fluid overload condition as well, or infection. So you can have fluid filled as well as air in the pleural cavity. Yeah, that's a fluid level. That's called hydropneumothorax. So you have pneumothorax and you have fluid level. You can have pneumothorax or hemopneumothorax. Again, is it filled with pus, or is it filled with blood, or is it filled with fluid? Hydropneumothorax. This probably need to be tapped and drained. Here you can see the nice fluid level here. Yeah. So it's a within pleural cavity. What do we have here? This is a child. There's adult's fingers holding them. NG tube, as you are guys now experts, you know it's in correct position. Do you think it's normal or abnormal? Left pneumothorax. So this is sometimes, this can be tricky because you want to trace a lung gauge throughout the lung entirely. And sometimes I'll start tracing it here and then I'll lose it here. And I'll go here and again I'll lose it, lung gauge. And I'm looking at these blood vessels and they're going past the lung markings, like here. And I'm thinking, oh wait, what can it be? The skin fold artifacts. So sometimes skin can get superimposed on the patient and it can cause this. So sometimes we're not sure about it. We'll ask to bring patient back and make sure there's no skin folds there, and we repeat the study. What's the line on the right side of the child? This is probably some kind of protection to protect parents' fingers, which is definitely didn't work. What do you think here on this one? Normal or abnormal? Again, looking at any metal foreign objects, cannot see. Mediastinal, heart, that looks normal. Any tracheal deviation, pretty straight. Looking at the lungs, looking at the pleura, what do you think? Is it normal or is it abnormal? Right, lower zone. Yeah, so you're seeing the margin. You can see the trace here. So I wanted to show another example of skin fold artifact here. You can see this axillary fold, and PEC goes over, and it makes it look like there's some kind of opacity going on there. But that's a skin fold, and you see this patient had just a different position. They breathe out, and it's all resolved, and it's no longer there. So that's just skin fold artifact. You want to make sure there's lung markings past it, so it's not pneumothorax. Incidental rib fractures here. What do we have here? This patient was in a car accident. This is patient, if you look at the demographics, it's supine, so they're not up, they're laying flat. Very good, spotted clavicle fractures. Clavicle fractures means there's been a high, there's a high intensity trauma with the clavicle fractures. First rib or clavicle fracture, this means there's a high acceleration trauma that's happened. Yeah. So you can see fractures. There's also fracture of the scapula here as well, little line. ET tube, correct position. NG tube, correct position. ECG leads here, ECG lead here. Yep. But now you're looking at the lungs because you're now very good at assessing the lungs, and you're looking at the pleura, and you're looking at this lucency here at this side of the lung. Because patient lying flat, any gas within the pleural cavity will collect in that position up because the lung is kind of in this concave shape. So this is called deep sulcocine. This is gas here, and this is pneumothorax. Yeah, that's right. This is pneumothorax. This is it's difficult. Sometimes they're very subtle, and yeah, you need to watch out for that. Compared to this, look at this side and look at this side. So if patient goes upright, it goes up, and you can kind of see the lung edge here. If I can convince you, you can see the lung edge. So yeah, pneumatoceles, you get them from trauma, maybe here, contusions. You can develop pneumatocele, basically traumatic rupture. You get cystic formation. On chest X-ray, diagnosing it, I'll probably be more looking at it on CT. What do we have here? This is just last one here, guys. Probably difficult to see. But okay, looking at the lungs, they look relatively clear. There is some atelectasis here. Atelectasis means a partial collapse of the lung. Can be secondary to infection, immobilization, post-surgery. All these lines, all here, atelectasis. We don't worry about it too much as long as it resolves. You might repeat imaging. Overall, lung fields look okay. Heart looks decent. Diaphragm looks okay. Airways. Tracheal deviation, yes, but then the X-ray is a bit rotated. So, yeah. And here we have some fractures of the ribs. It just shows case that when you have the X-ray, you go through the systematic approach. You're looking at the heart, you're looking at the lungs, you're looking at your review areas, epiphysis, diaphragm, behind the heart, axilla, and then you're looking at the bones and soft tissue. So you're looking at the bones. You want to make the bones look clean. You're looking through each rib like this, each cortex, and then you're going here, 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 and then here there's discontinuity, and you're going next rib, and again. So three ribs in a row can constitute a flail segment. There's different definitions of it. You might need three ribs with two breakage. So if they have multiple fractures, this could be flail segment. So they might need CT to rule out that. Thanks. Yeah, I think that's it, guys. Thank you very much. Appreciate this. Can be quite it takes a long time for you to kind of going through it. You probably guys now bored of it, but yeah, thank you very much for listening. I deal mostly with MSK radiographs. So if in future you give feedback, you want some more presentation with MSK related fractures, we will. I can sort of make another presentation more MSK related. But hopefully, I taught myself some chest X-rays. Thank you very much. I'll give back Dr. Kev. Continue. Thank you.
Hi, thanks for staying for so long. We did run over, which I thought we might do because we had so many cases, but hopefully found it all really useful. We do actually have, if you're interested in sort of learning more radiology, we do have an actual radiology series with Mind the Bleep. Let me just quickly get the link and I'll paste it in the chat. So essentially, we ran a course a couple of years ago, which covers pretty much everything you might want to know about radiology at a non-radiology doctor level. So we cover, structure interpretation and common cases and loads of pitfalls for all modalities. So chest, abdo-pelvic X-rays and upper lower limb MSK and CT as well. I'll just paste it here. So if you click that link, you should be able to get to the Radiology Mind the Bleep homepage. And then if you click on the video, you can then see that there's a playlist. And if you go through the playlist, you should be able to access all the different videos that we have. Please don't forget to fill in the feedback because that's how you get your attendance certificate. And make sure that you write in the open comments what you might want to hear what you might want for us to cover in the future. because we're trying to find things in radiology that we haven't already covered. But if you guys put in that you want certain bits for us to cover in the future, then we can try and arrange that. All right. Thanks for listening anyway.
Thank you.